think I can cover all of those topics, but I will certainly do my best. Well, welcome, and thank you for the invitation. It's great to be here. Let me get my slides started up. Great. My objective, as pointed out, is to give you an introduction to fluid management in the face of patients who have critical illness as well as ECLS. My focus is going to be more on critical illness because that's where the data is. Not in ECLS is going to be a byproduct of that, and I will show you some data related to fluid management on ECLS, but I'm going to focus my talk on the underlying principles. So I have no disclosures relevant to this topic. I wish I had some. The topics I'm going to cover are the following. Now, this list is just for the CME office. What I hope to do today is to make you think about and even change your approach to fluid management in terms of what fluids you give, how much you give, when you take it off, and so forth. And if I can achieve that goal, then I'll be extremely happy. The first thing I want to emphasize is that intravenous fluids meet the classification of a drug. Everything we know about drugs we can apply to intravenous fluids. They're used to treat disease. They have physiologic as well as pathophysiologic effects. They have a pharmacokinetic profile. They have a dose-response relationship. They can manifest toxicity, including organ dysfunction and as extreme as mortality. And they have indications and contraindications. So don't just think of fluids as something you grab a bag off the shelf and hang. You've got to think about your prescription for that fluid. Well, here's how we tend to categorize fluids. So resuscitation fluids, we break down into crystalloids, and I'm going to emphasize that's isotonic crystalloids, not hypertonic fluids, or colloids. Within isotonic crystalloids, we now make a distinction between balanced electrolyte solutions and saline. They used to all be considered the same, and I'm going to convince you that they're not. And that's why the saline is in a little red box instead of in a little green box. With colloids, we have albumin as well as non-albumin colloids. But in critical care, the use of non-albumin colloids has pretty much fallen off for a variety of reasons I'm not going to discuss, including in instances an increase in mortality. So I'll put a little red on the non-albumin colloids. Now, with respect to balanced electrolytes, I further break it down into plasma equivalent and plasma similar. And I'll go more into detail about what the composition of these fluids are. But plasma equivalents are going to be the ones you're familiar with: Plasmalite, Isolite, Normasol, all the same thing, different brand names. Plasma similar are going to be your Ringer's solutions. They're close to plasma-like in terms of their composition, but not exactly. And then we have the colloids, 4 and 5% albumin, depending on which country you're in. And the non-albumin colloids, hetastarch is the one that had been used most in the US. I'm not going to discuss non-albumin colloids anymore. What I want to present next is a very simple model of how fluid distributes within the body. Consider the body to be 3 different compartments with an interface between each compartment. On the left, the intravascular compartment. In the middle, the interstitial, and on the right, the intracellular. The border, the barrier between intravascular and interstitial is the endothelial lining of the capillaries. It's the interface between the blood and the interstitial fluid. The next barrier is between the interstitial and intracellular space, and that is the cell membrane. The cell membrane is impermeable to everything but water for practical purposes. And the endothelium is permeable to electrolytes and water, but not readily permeable to colloids or proteins. So we have 2 selective membranes. The size of these compartments I've put up here, they have some relevance. The intracellular compartment is about 2/3 of all body water. And of the remaining 1/3, which is the extracellular, intracellular is about 1/3 of that, and interstitial is about 2/3 of that. So when we administer fluids, we're administering it into the intravascular space, and we have to have a distribution from the intravascular space into these other compartments. So colloids, for example, will distribute primarily in the intravascular space. If we give a crystalloid, about 2/3 will rapidly leave the intravascular space into the interstitial space, and we're left with a smaller volume intravascularly. And if I were to give free water, such as D5W, or give a hypotonic fluid, that water component will distribute across all the compartments. And therefore, the amount that stays intravascular is going to be much, much smaller. If we lose fluid, we tend to lose fluid from all three compartments. Rapid fluid loss from the intravascular space is mostly going to be a loss of erythrocytes and cell components, as well as plasma proteins or colloid. However, if we don't replace that fluid very rapidly, what happens? We get a redistribution. Crystalloid starts moving in from the interstitial space to help fill up the intravascular space. That is the reason that we can get away with giving crystalloids to patients who have hemorrhage. Because even though they will drop their hemoglobin, we can still maintain intravascular volume and help to either replace or prevent the loss of interstitial fluid. And then over longer periods of time, such as with dehydration, we'll see water loss from the intracellular compartment, but that's a much slower process. Now, does this simple model have any basis? And the answer is yes. As simple as that model is, it actually explains things pretty well. This was a study done in patients who received, or subjects who received a 1 liter bolus over 15 minutes. And there were measurements of the plasma volume expansion. The very top line is 1 liter administration of colloid. Okay? So the volume expansion there was 1 liter. Crystalloid, the expansion was initially 700, but then dropped down to about 300, which is about the 1/3 that I talked about. And then if you give water, D5W here, then you're only expanding the intravascular space about 100 cc's. So that little simple model works, and we can use it to guide our approach to fluid management. I want to shift my attention now to the type of fluid loss that we see in critically ill patients that's not necessarily due to hemorrhage, and that is due to volume loss from the circulation from the intravascular compartment into the interstitial compartment, a breakdown of that barrier. The barrier between these two has fairly recently been identified as a complex structure called the endothelial glycocalyx. Anybody ever heard of that? Okay, well, it's kind of emerging, but it's a relatively recent finding. It is a protective layer that I'm going to discuss in more detail that sits on the surface of the endothelium of the capillaries that forms the barrier between the blood and the interstitial space. We used to think it was the endothelium itself. Here's an example of an early electron micrograph that shows the endothelium of the capillary, and of course it's not showing any glycocalyx. Why not? The reason we didn't know about the glycocalyx was because the fixation process for tissues for electron microscopy destroyed it. And it wasn't until newer fixation techniques came into use that allowed us to identify and study further this particular structure. So this is the endothelial gatekeeper. And this is a major functional component that forms that tight surface. It interacts with plasma. it's not, and it has a true interaction with plasma that I'll explain. It's not just a simple barrier. It helps to limit fluid loss from the circulation. It helps to keep the proteins where they belong. A breakdown of the glycocalyx allows for protein loss into the interstitial space, and it helps to reduce injury to the endothelial cell. The endothelial cell is very sensitive to shear stress and a number of other factors that can cause activation of these cells, but the presence of this glycocalyx shields it very readily from all of the things that can disturb the endothelial cell and cause the endothelial cell to get activated. And just as your skin, your epithelium of skin epithelium, there's normally ongoing low-level shedding with replacement. Other proposed functions of this very interesting part of our circulatory system is that it helps to retains proteins within itself, and it helps to provide the microenvironment for protection. So the glycocalyx uses plasma proteins as an integral component for protection against the exposure of the endothelium itself. And you can see where I'm kind of heading with this, that protein loss may result in protein loss from the glycocalyx. And as I alluded to earlier, it modulates shear stress. It keeps elements away from the endothelium such that they don't activate the endothelium, which can generate nitric oxide and alter microcirculatory blood flow. So what does this glycocalyx look like? It's a mess. It's composed of very long peptidoglycans that are attached to the surface of the endothelium, stretch way out, and these form the structural basis, but also plasma proteins are integrated into this complex as well and forms this nice mushy barrier that helps to keep things away from the endothelial cell. What choice does resuscitation fluid have on the glycocalyx? These are some very interesting findings which were published about 10 years ago. The graph on the left looks at plasma syndecan levels. Syndecan is one of the major peptidoglycans. So when the glycocalyx breaks down, it releases components. It's of the components that can be measured in the serum. So a serum level of syndecans, especially number 1, are associated with loss of the glycocalyx. So this is a measure of glycocalyx damage. And this was a model in which animals were subjected to hemorrhagic shock and then resuscitated with either ringers, a non-albumin colloid, and instead of albumin here, they used FFP. In post-resuscitation, one can see that following hemorrhage compared to sham, there was a loss of glycocalyx that was not restored by crystalloid and not restored by colloid, non-albumin colloid, but was restored by FFP. And likewise, this shows the thickness of the glycocalyx at baseline before the hemorrhage, about 0.4 nanometers thick. However, following resuscitation, just as we saw a drop in the injury pattern, we also saw a restoration of the thickness of the glycocalyx. So plasma proteins are going to play an important role in the permeability. They're not just there to act as colloids to help, quote, pull fluid in. They are actually a structural component of the glycocalyx that helps to prevent their loss in the first place. But the glycocalyx can get damaged. It can be sheared off. It takes time to get restored. It doesn't get restored very quickly. And when it gets damaged and the endothelium cell then gets exposed directly to the flowing blood in the capillary, then it has then the ability to lose proteins, and hence the loss of protein and the hypoproteinemia that can develop, the activation of white blood cells, monocytes, and other inflammatory cells. These cells can now attach directly to the endothelium. they can become activated and induce the microcirculatory component of inflammation that we call the inflammatory response. Other things can damage the glycocalyx. Just hypervolemia itself appears to do that, just giving too much fluid. And that's kind of new to me. You know, you think that just giving too much fluid just kind of allows for more fluid to leak out, but it appears that it's leaking out, in part at least, because of damage to the glycocalyx. And this was a study in healthy human subjects. I guess you can sign away anything you want to if you give consent, who were undergoing elective surgery, so they had a chance to be assigned to two groups where they got volume loading with crystalloid, or they underwent normovolemic hemodilution. So they had a blood loss but maintenance of the volume. So their plasma volume and blood volume stayed the same. They became anemic, as opposed to an increase in blood volume associated with volume loading. And you can see that in the volume loading group that the markers of injury to the glycocalyx are increased significantly, and they're not increased in the normovolemic hemodilution. So why this happens, we're not quite sure. Don't know if it's the volume itself, but it's thought that the hypervolemia increases release of ANP, or atrial natriuretic peptide, and it's been shown experimentally that ANP damages the glycocalyx. So we have a proposed mechanism that's related to ANP. The disruption of the glycocalyx results in loss of endothelial barrier protection, and we get all the bad side effects I talked about: leakage of fluid out of the capillaries, edema, platelet aggregation, inflammation, and loss of vascular responsiveness. And it can take days to restore this function after the inflammation is gone. And if inflammation persists, then you end up with this persistent loss of endothelial barrier function that can go on for long periods of time. So what clinical therapies do we have now to target the glycocalyx? Avoid volume overload. Plain and simple. Limit the inflammatory response, or source control. And I didn't mention it, but there have been some experimental studies that hyperglycemia itself can damage the glycocalyx. Is that the reason that our hyperglycemic patients have a higher mortality? Don't know. Limiting inflammation through the use of corticosteroids, and also other potential therapies I've listed here, including using FFP as part of resuscitation, which is now done routinely in trauma patients, or the use of albumin in resuscitation of other critically ill patients. Okay, I'm going to jump now to the coagulation pathway. Okay? On the left-hand side, we see the intrinsic pathway, and on the right-hand side, we see the extrinsic pathway. Gosh, look at your eyes. Jaws just dropped. Well, Elizabeth Moore reminded us this morning that 15, 20 minutes is the most you can take on any topic. So I switched gears. And now that I've got you redirected, we can get back to the topic at hand. So I want to talk a little bit about saline. I mean, it's the most common fluid given to patients. 200 million liters a year, and the vast majority of all crystalloids given. And you ask any physician, why'd you choose saline? Oh, that's either what we choose, or it's the same as anything else that I give. It's also considered to be equivalent and interchangeable. Swapping saline for ringers, ringers for saline, in most people's minds, that's essentially no difference whatsoever. But let's explore the history of electrolyte solutions. Electrolyte solutions date back to 1832. You can't read this, don't even try. But it's to show you that since 1832 up until the early 20th century, there were a variety of formulations of electrolyte solutions used to treat patients. every one of these, you have to trust me on this, every one of these has some balanced component. None of these contain pure saline. These are all sodium and chloride plus soda or bicarbonate or lactate or something else associated with it. Saline has never been used for resuscitation since the inception of these electrolyte solutions in 1832 until more recent times. Look at the bottom here, you can even see Ringer solution, which we still almost use today. And continuing on, you can see one of the most recent, I think this is 1932 Hartmann solution. Hartmann just did a minor modification of Ringers, and it is now what we know as lactated Ringers. That is the origin, and it dates back, some 80, 90 years now, and we're still using it today. But none of these early solutions bore any resemblance to sodium chloride. So where did sodium chloride come in? Well, blame this guy. Actually, he's not the culprit. But it started with Hamburger, who is a Dutch physiological chemist. And he was studying in a petri dish, he was studying what concentrations of electrolytes does it take to maintain a red blood cell with a normal volume. In other words, putting a red blood cell into hypotonic solution caused it to swell. Putting it in a hypertonic solution caused it to shrink. And he was working just with sodium and chloride because he was looking at tonicity. He wasn't really looking at the physiologic effects of any other electrolytes in our body, but just what osmolarity did it take. And it turns out that it took the osmolarity associated with 0.9% sodium chloride to prevent this. So, and he published these results, and that was the end of that for about 8 more years. Then an experimental pathologist named Barlow in 1896 started referring to his sodium chloride solution as normal. No basis for calling it normal other than the fact it was fairly normal in osmolarity in terms of sodium and chloride. That is probably the origin of normal saline, but there is no other basis for normality. And so it is absolutely uncertain how this finding jumped into clinical basis because there is no experimental or clinical basis for the use of saline ever, period. There was no one that did a study and said saline is great for doing this. It was not, again, for 100 years, had not even been used in clinical practice. So that seems to be the origin, and we ended up being stuck with it for a very long time. Now, let me show you this study. This is a study in proctoclysis. Anyone know what that is? Clysis, dermal clysis is used by veterinarians where they infuse fluid under the skin in animals. I've done dermoclysis in pediatric patients. It's a way of getting fluids in without using an IV. Where proctoclysis is, well, you don't have an IV, we don't have IV needles, put it in the rectum, and it's absorbed. So proctoclysis was a very common way to give fluids before the common use of intravenous fluids. And note the description on the right. It's true that sodium chloride is the least toxic of the group of similar metal chlorides, but even at that, it is a poison to all people when given in large doses. And to a certain class of cases, we believe this peculiarity is apt to be present in resisting powers whose resisting powers are lowered by operation. So if you give enough to anybody, it's toxic. You give a little bit to patients with certain conditions, it's also toxic. That was their clinical observations. And post-op patients and septic patients were the two that he said, it can be bad for you if you have these conditions. What year was this? No idea? 1913. How long have we known about this? Or has it been brought to our attention? Again, 1928. for the treatment of cholera primarily. The administration of large amounts of saline with diarrhea and oliguria is contraindicated. So he not only said it's bad, he says just don't do it. So why has this not stuck? But it has not, because he says this can produce fatality. And this is Hartman, who created Hartman's solution a few years later, now known as lactated ringers. So what are the composition of these fluids I'm talking about? For reference, on the left-hand side, and I'm just going to point out, we're most focusing on sodium and chloride. Sodium 140 in plasma and about 100 of chloride in plasma. Let's move to plasmolyte, which is what I call a plasma-like crystalloid. Sodium 140, chloride 98. There's acetate and gluconates, and those are things that kind of get substituted for our bicarbonate and our anion gap. But essentially, in terms of sodium and chloride, almost identical to plasma. Lactated ringers, a close second. Sodium 130, so it's a little hypotonic, about 10% free water. But relative to the low sodium, you've got a fairly high chloride. So it is nowhere near the chloride of saline, but a little bit. So yes, it's an okay fluid. And it was the most popular fluid used in trauma resuscitation for decades until sometime recently saline came along. It got reinvented. I don't know how that happened. But you can consider plasmolyte and ringers to be relatively interchangeable, except the fact that you have a little hypotonicity, which might have relevance in patients with head injury. So be careful about that. Then we move to saline, 154 sodium, 154 of chloride. So the osmolarity of these three are very similar, but the fact that there are no other electrolytes in saline means you have to have a higher chloride and a higher sodium to achieve the same osmolarity. And this is where the problem is. There is the, if you're into strong ion difference, this is a strong ion difference of 0, which induces an acidosis in patients. And furthermore, this is a little scary. This is a study of patients, an animal study looking at vascular permeability in the glycocalyx during sepsis, a model of sepsis. That when resuscitation with saline was implemented, there was loss of the glycocalyx. So this gives some evidence to the fact that saline itself, as a fluid, can be dangerous. So let's look further at septic shock and saline versus balanced solutions. Most of the studies that have been done looking at these two in patients with sepsis or ICU patients showed no significant difference. But when I looked at the ones that didn't show any difference, the volumes of saline give were fairly small, 1.5 liters. That doesn't touch anything. But when you give larger volumes, that's where the difference comes in. So this was a retrospective study which looked at, it was a retrospective cohort study, but there was 6,700 propensity matched patients. So it's not a small study. It's a fairly large, although retrospective. And looked at saline only versus balanced fluids of varying proportions in vasopressor-dependent shock. So the sickest patients. And the absolute in-hospital mortality was significantly different, with a high degree of statistical significance. And furthermore, they went on to look at the mortality associated with the relationship of how much of the fluid was saline. So if you had it was balanced. So if you had 100% of your fluid given as balanced electrolytes, your mortality was here. And that mortality went up as your proportion of saline got higher and higher. So this demonstrates a dose-response relationship between the amount of saline given and mortality. So what are the considerations? There's a growing body of evidence that balanced solutions are preferred over normal, or as we call it in our institution, abnormal saline. The benefits appear across many clinical spectra, and importantly, no study has ever shown the superiority of saline, ever. They've shown equivalence in smaller studies, but none have shown the same. There is a potential for harm identified in numerous studies, and I have not really touched upon all of the things that saline can do. It can affect renal blood flow and cause a reduction in renal function. I'm not going to touch any of that, but balanced solutions should be considered as first-line agents, and saline should be used when specifically indicated. But I will admit, we're dealing mostly with retrospective and perhaps propensity controlled or matched studies. We still have the need for better designed trials, but they need to take into consideration things such as dose and so forth. So, what do bloodletting and saline infusion have in common? There is no physiologic or clinical basis for either, including saline as resuscitation fluid. They've lacked efficacy compared to other treatments. They're capable of harm and continued use without any evidence. All right, I'm going to jump to albumin, since it's now the major colloid that we have available to us in the U.S. It's a contributor to oncotic pressure, which helps to maintain fluid within the lumen of the capillary. It is an important component in the integrity and the function of the glycocalyx, which I now introduced you to. It is an antioxidant. It's a free radical scavenger. It has a number of other pharmacologic effects other than being just a colloid. It has some limited anticoagulant and antiplatelet activity, and it binds and transports numerous ligands, not only electrolytes, but other drugs and so forth that are important in the way we manage patients. And it also serves as a buffer in acid-base balance. And there are decreased levels in critical illness from a variety of reasons. The loss of the glycocalyx allows albumin to leak out. There's an increased degradation. We're not feeding our patients. They've got to get metabolism from somewhere. And when you have an inflammatory response, you make less albumin. So you're losing it, you're using it, and you're not even making it. So hypoalbuminemia is a characteristic of critical illness. So what about replacing it? Well, I cannot cover in a short period of time all of the crystalloid versus colloid studies, but I just want to point out some of the more recent, this recent study and a meta-analysis. The ALBIOS trial was a study in which they didn't really use albumin for resuscitation, but they gave it on a continual basis to critically ill patients to keep the albumin above 3 grams per deciliter. And so it was a daily infusion of albumin as needed to keep it up. And in the overall group of all sepsis patients, there was no difference. There was a slight mortality, survival advantage to albumin, but it did not reach statistical significance. But when they went and looked at whether septic shock was present, this was a predefined subset. In the absence of sepsis, there was clearly no difference, but in septic shock, there appeared to be a survival advantage, a significant decrease, barely significant, but a decrease in mortality. And here's a meta-analysis using albumin for severe sepsis and septic shock, looking at several studies together in sepsis, showing again overall in just sepsis patients, no significant difference. But if you focus down in those septic shock patients, the ones that we know have the dysregulation of the peripheral vascular system, the ones that have the damage to the glycocalyx perhaps more than any other group, these are the ones that showed a significant improvement. So, and this was a recently published, this is published about 10 years ago. And again, based on recent studies and the meta-analysis, there's data that suggests that albumin and maintenance of avoidance of hypoalbuminemia in patients with severe sepsis and septic shock may be a good target. How do we replace fluid in critical illness? Well, if your goal is to expand the intravascular space, then you're going to focus more on colloid, which is why we now have the return of FFP and other protein-based fluids to our trauma patients. But crystalloid is going to expand what most patients lose in both the intravascular and interstitial. All right, so I've got 5 minutes left, so I'm going to go over some slides very quickly and skip some others. But fluid overload and septic shock is a vicious cycle. They get hypovolemic, they get fluid, they get edema, they get abdominal hypertension, they get oliguria, they get a number of things that causes a cycle of fluid administration. They get on vasopressors, they get, and Phil was talking about this a little bit earlier. Something that is coming to the forefront, first identified in post-transplant kidneys, is that the swelling we see in patients with edema also happens in the kidney. The kidney is in a capsule. It prevents it from expanding. And low levels of protein associated with peripheral edema is also associated with edema in the kidney and increase in intrarenal pressure and loss of renal blood flow. So hence, the reason our patients get oliguric may be partly related to the fact that we are overloading them with fluid. I don't have time to go over all of these. This is a whole 2-hour talk in of itself, but every organ system and the function of every organ in the body, including the brain, the gut, the heart, the respiratory muscles, is affected by fluid overload. Does it impact outcome? Yes. This is a fairly recent meta-analysis published in 2020 of observational studies, because we don't have any really large good studies, but everyone consistently shows that fluid overload is associated with mortality in ICU patients. Okay? That is true for ECMO patients. I'm not going to go into the details of this slide, but when ECMO patients were looked at as well, those that had a higher 72 hours, had a higher volume status, had a lower survival, shown here in the red line. And what was shown here is that this is the same data. Fluid overload, 4 times the mortality with fluid overload at 3 days. 4 times. It's not trivial. Does treating volume overload early and trying to prevent it help? It appears so. And this is data here that shows that non-survivors had a higher fluid balance that compared to survivors, in which they were able to keep the patients from getting hypervolemic in the first place. How do we get fluid off? Diuretics, a lot of limitations in ICU patients. Hemofiltration or ultrafiltration, great for getting fluid off, but does not affect clearance. And what we do nowadays is we go to continuous renal replacement therapy machines. We plug it into our ECMO circuit, and we dial in what we need. We dial in fluid removal, we dial in renal support. This shows that getting the amount of fluid right is correct. If you underdose patients with shock, you have a higher mortality than if you dose them right. And if you overdose, you can see the same curve. So it's not, you have to give the right amount. Patients in shock need fluid. It's just giving them only what they need. And that's where it comes in, we have to assess. Everybody heard of the 30 mils per kilogram in sepsis patients? Okay? Throw it out the window. There's no evidence to support it. It has potential for bad outcome, and it should not be used in sepsis, despite the fact that hospitals are forced to use it. So that's something we have to deal with. So what do we move to? We need to assess whether patients need fluid. You've heard of the concept of preload. 20 years ago, 30 years ago, we used to optimize preload, intravascular volume. Then we recognized that some patients, a normal preload, we could improve upon. So we now have moved to an era of preload responsiveness. Do they get better when we give them fluid? And that's due to the fact that not everybody's cardiac function curve is the same. So along came the respiratory variation in stroke volume or stroke volume variation. IVC diameter. These are valid, but they're not valid in the majority of our ICU patients. So we toss those out the window. What do we have left? What we have left are these two. The passive lag raising test. Moving a patient from a position with the head up and the feet flat to head down and feet up provides an immediate bolus of about 300 cc's of fluid. And as long as you're monitoring some hemodynamic parameter continuously, such as a stroke, you have an art line with stroke volume variation or a bioreactance device, and you can immediately see if there's a change in cardiac output. Or you can use echocardiography. And the other option on ventilated patients is the end expiratory occlusion test. Again, you hold a patient in end expiration, which then gives time for fluid to accumulate, to be back up, and then when you release it, then you can see all that fluid coming back, and that provides a very similar type of test. So using these dynamic tests are now recommended and can help us to target the amount of fluid a patient needs and avoid overload. So takeaway thoughts: treat IV fluids as you would medication, choose the right dose, and choose the right drug. And I propose that we should be dropping saline where it's not specifically indicated, and consider albumin in patients that described, especially with severe sepsis and septic shock. And the only thing we haven't worked out yet is why albumin appears to result in a poor outcome in patients with traumatic brain injury, and that's still, the jury's still out on that. Okay, thank you very much.
We have time for one comment.